It is estimated that more than 3,000 women will be diagnosed with breast cancer in Wisconsin this year. The importance of early detection and treatment options, next on Healthy View. Thank you for tuning in to Healthy View. I'm your host, Michael Frona. The Bellin Foundation and Bellin Health are proud to bring this program to your community. Healthy View is a weekly program designed to help you with health issues from A to Z to help you live a longer, healthier life. Today's program is about breast cancer and breast cancer awareness. To help us understand this very common disease, we have two local experts, Dr. Edie Krieger, a radiation oncologist, and Andy DeLeo, the team leader at Bellin Health for Cancer Services. Hello and welcome to both of you.
Thank you for having us.
Thank you.
You're welcome. You know, anywhere we go, literally, we can meet somebody who's had breast cancer in their family, who's been recovered from breast cancer themselves, and maybe even tragically, we know somebody who has died from breast cancer. So it is a fairly common disease, but yet many things are changing with it. Dr. Krieger, you've been a radiation oncologist for all of your professional life. Why did you enter the field, and what brings you the satisfaction, and what is the challenge of the field that you're in?
Radiation oncology is a wonderful field. I love what I do. It gives me the opportunity to use the latest technologies in the treatment of cancer and really make a difference in this disease entity. In fact, I would say that breast cancer is the biggest reason for my decision to go into radiation oncology, because radiation plays such an important role and has really made differences in improving the cure of this disease.
You mentioned that you believe that you can make a tremendous difference in the lives of women who have breast cancer, and that is a topic that we're going to explore in the next half hour. But before we do that, let's meet Andy DeLeo, who is with you today, and you're the team facilitator at Bellin Health for Cancer Services. What does that mean, and where does your satisfaction come from professionally?
Well, first of all, what that means is that I'm actually heading up a new oncology or a cancer program for Bellin Health. And there's going to be a new cancer center that we will be creating for the Green Bay community to bring top-of-the-line technology and cancer services to the community. But really where I get my professional satisfaction from when it comes to cancer care is sort of three things. One, I'm really interested in technology and getting to know different things and being able to use cutting-edge technology. The second thing is just getting to know patients and really communicating with them, developing relationships, and just being challenged every single day. And radiation oncology and the cancer population really offered me sort of those three areas.
That's really a nice package to meet your professional interests.
Exactly.
Dr. Krieger, those four words, you have breast cancer, really have to put people's lives upside down, sometimes temporarily and sometimes until they unfortunately die of the disease. When you are finding in your practice that you have to communicate that and then work with that with a patient, what is that like, and what do you help patients understand about those four words, you have breast cancer?
It's incredibly difficult, and I have to say that especially with breast cancer, it's even more so difficult for the reason that these women who get the diagnosis, pretty much it hits them out of the blue. You know, they're mothers, working, professionals, and actually living fairly healthy lives, and active lives, non-smokers. So it just hits them out of the blue, and it's a very difficult discussion when we start to talk about how to treat and what the prognosis is.
I don't want to make light of this very serious disease, but Dr. Krieger, is all breast cancer created equal? Are there different kinds of breast cancer, and if there are, what exactly are the differences?
Definitely not. There is a broad spectrum of breast cancers. It could be non-invasive breast cancer, called ductal carcinoma in situ, or invasive breast cancers. And even with the invasive breast cancers, the majority of those cancers are localized and very treatable and curable.
What really is the fundamental difference between an invasive and a non-invasive breast cancer?
The cells have, with invasive breast cancer, the cells have invaded what's called the basement membrane. And that's really a barrier from where the cells in the duct of the breast reside, and then on the other side, in the wall, if you will, or across the wall, are the lymphatic channels, whereby, if they invade that, can potentially go to the lymph nodes and other sites of the body.
So if I'm listening to my diagnosis of breast cancer, am I going to want to hear invasive or non-invasive?
You're going to want to hear non-invasive. But again, I'll emphasize that even with invasive breast cancers, a good majority of them are localized, only because detection has become so excellent that we find them at early stages, stage 1, stage 2, at invasive breast cancers that are still curable and treatable.
A little earlier, when you indicated that sometimes when you have to tell a person that they have breast cancer and you look at them and otherwise they're a perfectly healthy person, they're a non-smoker, that made me think about the risk factors for breast cancer. What are some of those risk factors, Andy, for breast cancer, and how can a person be more aware of that if it's part of their history or their habits?
There's quite a few different risk factors for women. One of the risk factors would be if they've had a mother or a sister or a direct relative that has had breast cancer. That could increase their chances for having breast cancer themselves. Not having children at all, or not having their first child until after age 30 can increase your risk for breast cancer. Either actually having menarche or getting their period at an early age, and then that period or going into menopause at a later age can increase your risk for breast cancer. And then also obesity after menopause. And then I'm not sure if there's any other ones that I might be forgetting.
Hormone replacement therapy that used to be commonly prescribed for postmenopausal symptoms, and now I think we're thinking a little bit harder before doing that, only because there is a real link that it's caused breast cancer. I really want to talk about these modifiable risks that Andy has just pointed out to. I mean, some of these things like personal history of breast cancer, family history of breast cancer, those things you can't change.
That's right, you're born into that.
That's right, but breast cancer, for obesity, one of the most interesting facts that I know about is, well, obesity is clearly linked to breast cancer. And they did a study of Japanese women where Japanese women, by the way, have the lowest risk of breast cancer of all populations. But they took a sect, or they studied a sect of Japanese women who immigrated to the United States. So they were born in Japan, immigrated to San Francisco, and then ate the American diet, and then compared their risk of breast cancer with their generations before them or their family members still in Japan. And their risk of breast cancer is exactly the same as the population in San Francisco or Northern California.
What an amazing
Very
study.
amazing, I know. So it really tells you that, you know, you can do, you have some control, that, you know, you can modify some of these risks to lessen that.
What are some of those nutritional habits that people should try to avoid? I mean, every label you pick up would cause cancer in some sort of lab animal. Mm-hmm. I know that's
right.
being a little far-fetched, but what can a person do in terms of their nutrition intake to limit or minimize their potential risk of cancer from those controllable sources?
Mm-hmm. I mean, the obvious thing is, you know, decrease the fat content in your diet, eat, you know, vegetables, you know, good serving of vegetables and fruits. Just a very well balanced. Everything you hear, you know, the recommendations that you hear out there will apply.
Now, you haven't mentioned tobacco use or smoking. Is there a link between smoking and breast cancer? We know that there's some links between other forms of cancer and heart disease, but is it linked to breast cancer?
I'm sure there is a link that's been found, but it's not one of the strongest risk factors, which is, again, you know, when I'm in the room talking or explaining that the patient has breast cancer, it's quite difficult because a lot of them are not smokers, you know, are not drinkers, are mothers, and that's a difficult diagnosis to give.
And it really, as you pointed out earlier, catches them really off guard. Yes. and turns their life temporarily upside down. Mm-hmm. Will a woman know if she has breast cancer? I mean, what are some of the symptoms and signs that there might be something going on?
Well, it kind of depends. Women should actually probably start doing self-breast exams at home. Probably start doing them in their 20s. And there's some very good recommendations and some good literature out there from the American Cancer Society mm-hmm. that actually goes over how a woman should do a breast self-exam. And then, you know, just getting, I guess, used to how the breast tissue actually feels, that you know, if they do it on a routine basis, that they can actually discover a lump or changes that may not be normal. And if that does occur, then that's when they should really go out and start to seek a professional opinion.
So I know there's some of the things I've read talk about a tenderness or a swelling or a discharge. Those would also be signs that there could be cancer present?
It could be. But really the most common way that we detect breast cancer now is through mammograms, mammographic changes. So get your mammograms, I think.
Sure, that's a good message too.
Yeah.
Do they hurt as much as women say they do?
I have not personally had a mammogram, so I can't say personally, but that is a common theme of all my patients. Boy, do I have to get that study again.
but better to have it and know you're cancer free than
Absolutely.
To not have it and discover you're in some later forms of cancer.
Absolutely.
Well, and that's one of the things that research has also shown, is that having routine mammograms, you can actually detect cancers earlier, almost 2 years earlier than what a physical breast exam can detect. 2
years. That's
yes.
significant.
Yeah.
Because a lot can happen if your cancer is developing and those cells are changing over those 2 years. It may be too late. It may be more of an invasive versus a non-invasive.
Now, I'll say that mammograms are not recommended routinely for the standard population or the general population. So someone with standard risk, meaning no relative having had breast cancer or personal family history of breast cancer. Really, the routine is to start at the age of 40. And get yearly mammograms after that.
But a woman can partner with her OB/GYN or their primary care doctor to find out when is the best time for them to get mammograms.
Definitely.
Well, we've talked a little bit about the causes, the risk factors associated with being diagnosed with breast cancer. And after the break, we will come back and talk with you about the many different treatment options you have if you or a loved one are diagnosed with cancer. We'll be right back. Today on Healthy View, we're talking about breast cancer awareness, the importance of early detection, and the treatment options if you've been diagnosed with breast cancer. Helping us to understand this very important topic are two local experts, Dr. Edie Krieger, a radiation oncologist, and Andy DeLeo, who is the team leader at Bellin Health for cancer services. Before the break, we were talking a little bit about what happens when you've been diagnosed with cancer and what are some of the risk factors that lead up to perhaps having breast cancer develop in the first place. And for the last half of today's program, let's focus in on the options for treatment. I know that there are some people who are very comfortable staying in the area for their treatments. There are other people who go other places for their treatment. What options exist today, and what are some of the more recommended or popular options for treating somebody with breast cancer?
For local, I said in the earlier, the first half of the show, that the majority of breast cancers are localized, and so treatment is highly focused on, the local breast treatment. And a lot of times, a common point of view is, well, I'll just get my breast off and then I will be fine. But actually, in the 1980s, huge studies were done across the country. Thousands of women participated, looking at exactly that question. Do you need a full mastectomy, or can you get away with a lumpectomy, which is basically just excising the tumor itself, followed by radiation for several weeks? And there is absolutely no difference between the two options. And that still holds true after 25 years of follow-up. So women have the option, absolutely, of keeping their breasts as long as the cancer is localized. And that's where Andy and I play a role anyway with respect to radiation, is that more and more women, and rightly so, are choosing breast conservation therapy, meaning electing to keep their breasts, having the lumpectomy done by a general surgeon, and then following it up with radiation.
And that's where the work that both of you are involved with comes into play, the radiation of that cancer after the surgeon does what they need to do to remove that cancerous part of the breast. What options in terms of radiation are there?
There are lots of options. Go ahead, Andy.
As far as different options for radiation, there's external beam radiation or radiation therapy. That's, I would say, probably the largest majority, an umbrella of what all patients are going to receive. There's different forms of external beam radiation therapy. There is whole breast radiation therapy, where we actually will administer a radiation beam to the entire breast tissue. There's newer technologies called IMRT, or intensity modulated radiation therapy, but that's
Andy, I'm sorry, say that again. What the difference between the whole breast beam and the second beam was?
It's IMRT, or intensity modulated radiation therapy, but what's really nice about that is it actually allows us to basically paint the radiation to just the area that we want it to within the breast. So we can get a higher dose to the breast area, and we can really reduce or decrease the exposure of radiation to normal tissues.
Especially the heart, for example. Left-sided breast cancer, is, of course we see that. And the heart is sitting right there up against the chest wall, and so the techniques such as intensity modulated radiation that you refer to really allows us to minimize the dose to the heart, because we, quite frankly, I think that we will cure the majority of patients with localized breast cancer. So they're going to live long lives. Well, I don't want them to live long lives and have heart problems. Can't do the things exactly because of the cancer treatment. So these technologies have just come about in the last 10 years, and I think Andy and I are just firm believers that we use the technology to its fullest, so that women are not only cured but then live, healthy lives beyond the cancer.
If I'm sitting with my physician and I've been told I have breast cancer and you're going to need radiation, am I to know what kind of radiation is best for me, or how will you help your patients understand what's best for them?
The family physician will refer a patient to a radiation oncologist and a general surgeon, where, at the table hopefully they discuss what the best treatment option is, and then decide up front which radiation therapy modality would best treat their cancer.
And I think one of the things that we're looking at doing a little bit differently is actually really coordinating the care of patients. In particular with breast cancer, once you do have that diagnosis, really all you can really focus on is the word cancer. You have cancer. And you know, as we all know, sort of trying to get appointments arranged with a surgeon and maybe a medical oncologist or the chemo doctor and a radiation oncologist can kind of be a daunting experience. And sometimes it can get to be a little overwhelming and dysfunctional, and just trying to navigate a healthcare system when you're trying to deal with the fact that you have cancer as well. So what we're actually looking at doing is having a cancer care coordinator assigned to each of the patients that is their point of contact and their point of reference, and that coordinator can actually go ahead and help set up appointments, help to transfer the information so the patients really understand what's going on, but the patient can really focus on their family and their diagnosis and getting better, and then we can worry about getting the scheduled appointments and making sure that everything's going on correctly and they're getting the best information to make the best decision for their treatment.
You know, and I think that's a really good service that'll be provided, because you want the person to focus on their hope and getting well. But how do I know the information I'm getting? When you say give you the information you need to make the right decision, as a person or a family member with somebody with breast cancer, how do I know I'm making the best decision based on the information I received? Are there things, are there resources other than my doctor where I can turn to? How do I make that decision?
There's a lot of different resources. The American Cancer Society has a lot of good information, especially in regards to breast cancer. There's also the National Cancer Institute. They have great information that's out there. And then there's also some specific breast foundation programs that are out there that you can go and you can get different information about different diagnoses, different treatment options. But really, I think what the best thing for all the patients to do is actually to see all of their physicians, you know, maybe in one day, and have that coordination between the surgeon, the chemotherapy doctor, and the radiation oncologist.
So by and large, I can be somewhat more at peace with the decisions that are being made along with my providers, so that I can focus on getting well.
Correct.
There are different kinds of words I've heard, like tomotherapy or linear accelerators when it comes to radiation. What is the difference between how those two are applied, and can I expect different outcomes if I choose one or the other?
Yes, we have lots of different modalities. There's lots of other words, you know, that I could throw out as well, in addition to linear accelerator or tomotherapy. But each one is highly specialized, and so each one has to be applied to the right clinical situation. And so physicians have chosen, or the modality, that best suits the clinical situation.
The kind of cancer,
yes,
like where
yes.
it is. And
just because you get tomotherapy, it doesn't mean necessarily that, you know, you're going to do better, because maybe that wasn't the right technology per se. That's just an example.
So the outcomes are really going to be based on the kind of cancer one has, then with the professional expertise of a person such as yourself, Dr. Krieger, would make the best decision for that patient to achieve the best possible outcome.
Yes.
What risk factors are involved with radiation therapies?
Mm-hmm. We break them up into two major categories. There's acute side effects, or side effects that occur during the actual treatment, and then long-term side effects or complications that I've already alluded to. The side effects that typically occur with almost any type of radiation for breast cancer is skin redness, maybe skin peeling, tenderness. But that's really self-limited, meaning that when the radiation is done, about 2 weeks after the radiation is completed, you won't even know that you've had radiation. The skin changes resolve. which is why I focus a lot on limiting the long-term complications, because those are the permanent.
Those are more significant.
Yeah, the permanent damage, the damage to the lung, the damage to the heart, you know, even to the shoulder, meaning that, you know, if you aren't careful and are mindful of where the radiation beam goes, you know, you could have permanent arthritis of the shoulder. You know, things like that are you know, going into a plan and planning a radiation treatment are really things that I think about. In addition to, of course, making sure that you treat the entire target, so that way, you know, you can eliminate the cancer, right? Obviously.
Are the risk factors, are they greater as the radiation is longer over time?
Not necessarily. Not necessarily. That's really. It depends on how much you get each day as well, and it depends on as well as the length. There's a lot of variability in that. So just because you receive 6 weeks of radiation versus someone who only received, you know, one week of radiation doesn't mean that you're at greater risk of a complication.
We just have a few minutes left in today's program, and we've talked a lot about the significance of breast cancer in one's life and some of the treatment options. I like what you said about you can help people go on living a longer, healthier life even after breast cancer, but there's also a recurrence, and when the recurrence happens, people still need to be courageous and have hope, because there are therapies that can help even in advanced stages of cancer, I know, and perhaps on another show we can talk about what happens when cancer recurs in other parts of the body from the original source of breast cancer. So I don't want to go there today, but what message would you like to leave with our viewers today about maybe the importance of early detection and getting the care right away that you need? Dr. Krieger?
The death rate from breast cancer has started to decline, and the reasons for that are, one, our detection is much better with the use of mammograms and MRI, which we don't have time to talk about now, and so close follow-up with your family physician is key, and getting your mammograms 40 years and there beyond. And then secondly is better treatment, not just radiation, but there are better chemotherapies and hormone therapies, which we were unable to discuss today, but hopefully you'll have us back.
Time.
Yeah,
that's right. Andy, what would you like to leave our viewers with today?
I would like to leave our viewers with just the notion that just because you were told, and once the physician walks in, that you have breast cancer, that it's not a death sentence, that you should have hope, and you should really focus on yourself and your family, and that there are plenty of cures out there.
And that you can live a longer, healthier life, and there are other women who have gone through what you're going to be going through, and certainly they've made it, and the support group and the dynamics of that can be very helpful as well. Well, thank you very much, both of you, for being with us, and thank you very much for joining us at home. If you'd like more information about cancer services and the options you have if you're diagnosed with cancer, we invite you to visit our website at www.bellin.org/healthyview. If you have a show topic you'd like to see, please let us know that too. Until next time, I'm your host, Michael Frona. Have a healthy week.